Thyroid tumor classification and staging. The follicular cells give rise to differentiated thyroid cancer, anaplastic thyroid cancer. So follicular cells, two types of cancer arise: anaplastic and differentiated thyroid cancer. The parafollicular C cells, they give rise to medullary thyroid cancer. Then there are immune and stromal cells, they are responsible for lymphoma and sarcoma. 90% is differentiated thyroid cancer, 5 to 9% are medullary thyroid cancer, and 1 to 2% they are anaplastic thyroid cancer, and 1 to 3% they are lymphoma. Less than 1% is sarcoma. And many systems have been proposed for staging of thyroid cancer, and the TNM, that is tumor node MAT system, introduced by the International Union Against Cancer, promoted by the AJCC, has been adopted. Now we will see the genetics and characteristic of the familial thyroid cancer. So first is papillary thyroid cancer with papillary renal hyperplasia, which is seen on chromosome 1q21, which is associated with the papillary neoplasm, autosomal dominant with partial penetrance. Then there is familial medullary thyroid cancer, familial non-medullary thyroid cancer on 2q21 19p13, which is two genetic loci identify autosomal dominant with partial penetrance. Then familial thyroid tumor with cell oxyphilia on 19p13, and characteristic, there are oxyphilic cells and dominant autosomal dominant with partial penetrance. And then there is familial adenomatous polyposis gene, which is on 5q2122 APC gene. It causes papillary thyroid cancer with the cribriform morular variant, colorectal cancer, ampullary cancer, hepatoblastoma, medulloblastoma. It is autosomal dominant. Then there is Cowden disease, that is multiple hematoma syndrome 10q13, which causes papillary and follicular thyroid cancer, multiple hematomas, breast and endometrial cancer, and autosomal dominant. And then there is Carney syndrome, Carney complex 17q PRKAR1A, which causes follicular and papillary thyroid cancer, skin pigmentation. Then there are cardiac, endocrine, cutaneous, neural myxomas, and autosomal dominant. So this is AGCC staging. T0 is no evidence of thyroid cancer. T1, which is divided into T1A, which is less than 1 centimeter in the greatest dimension, limited to thyroid. T1B is 1 to 2 centimeter in the greatest dimension, limited to thyroid. T2 is 2 to 4 centimeter, limited to thyroid. Then T3A is more than 4 centimeter. T3B is extrathyroidal extension, only to strap muscles from tumor. T4A is extrathyroidal extension, involvement of the subcutaneous soft tissue and larynx, trachea, esophagus, recurrent laryngeal nerve. And T4B is invading prevertebral fascia, encasing carotid artery or mediastinal vessels. Then N0A is one or more cytologically or histologically confirmed benign lymph node, and N0B is no clinical or radiological evidence of locoregional node. N1A is metastasis to level 6 and 7, that is pretracheal, paratracheal, prelaryngeal, upper mediastinal, can be unilateral, bilateral. And N1B is unilateral, bilateral, contralateral lymph node to level 2, 3, 1, 2, 3, 4, 5. M0 no distant mets, M1 is distant mets. Now we will study about the differentiated thyroid cancer.